Hi everyone, I chose hyponatremia for my flashcard topic this week. I see a lot of patients with hyponatremia in the hospice, and it can be incredibly difficult to manage these patients at the end of life. The pathophysiology behind hyponatremia is it's a low sodium concentration in the blood, which is caused by either a bodily loss of sodium or an excess of water in the extracellular fluid, thus kind of causing dilution. Typically, water follows sodium, so with hyponatremia, there's an imbalance of that relationship. With that being said, there are three types of hyponatremia: hypovolemic, hypervolemic, and euvolemic. In hypovolemic, we see a decrease in total body weight, which is greater than the decrease in total body sodium. In hypervolemic, we see an increase in total body water, but it's greater than the increase in total body sodium. And in euvolemic, we see an increase in total body water, but there's a stable level of total body sodium. All three of these lead to impaired nerve conduction and decreased osmotic pressure in extracellular fluid, which leads to a fluid imbalance, and this can lead to brain cell swelling. There's also such thing as pseudo-hyponatremia, which is a falsely low sodium level, and this is typically present in patients with hypertriglyceridemia or multiple myeloma. And this is simply because their lab samples they lead to the lab's inability to properly identify sodium concentrations. Risk factors for hyponatremia include excessive sweating, any GI fluid loss such as vomiting and diarrhea, diuretics, pancreatitis, small bowel obstruction, hormonal imbalances, severe burns, early renal disease, excess water intake, CHF, cirrhosis, drugs and certain medications, SIADH, Addison's disease, hypothyroid, malabsorption, diabetic acidosis, and nephrotic syndrome, just to name a few. The major signs and symptoms of hyponatremia include loss of appetite, nausea, muscle cramps, fatigue, weakness, headaches, hypotension, confusion, and in severe cases, we see seizures, coma, and death. This image was borrowed from an educational video from osmosis.org, and it's essentially reiterating what was already stated, that hyponatremia is a result of losing more sodium than water or gaining more water than sodium. Diagnostic testing includes a serum sodium level, and this is obtained from a blood sample. Typically, this is reflected by a level less than 136 milliequivalents per liter in adults and children. Physical assessment is important when we're thinking about the cause. Whether edema is present or not. It could be the difference between hypervolemic versus hypovolemic, and thus it's going to navigate how we treat the patient. Other helpful diagnostics include serum osmolality, urine osmolality, and urine sodium level. Again, treatment depends on the etiology and whether the condition is acute or chronic. A lot of patients with chronic hyponatremia are treated with scheduled salt tabs, fluid restrictions. Again, it really depends on the type of hyponatremia. The goal of correction is typically no more than 8 to 12 milliequivalents per liter in 24 hours. And this is because when hyponatremia is corrected too fast, it can lead to osmotic demyelination syndrome or shrinkage of the brain cells, and this can be fatal. And I think that's it. So thank you for watching.